Okay, a lot of information. So we're going to get started on the NATA's pre-participation physical examinations and disqualifying conditions physician statement, and also talk about sudden cardiac death. The participation of athletics is on the rise. In 2010-2011, more than 7.6 million high school students played sports, or in 2005-2006, there were 7.1 million. This growth has led to a rise in sudden death. Most are amongst those with a congenital or cardiovascular malformation. They include your male football and basketball players and can also include heat stroke, cerebral aneurysm, commotio cordis, asthma, and sickle cell trait. Commotio cordis is often a lethal disruption of heart rhythms that occurs as a result of a blow to the area directly over the heart. The adoption of PPEs. This ensures a safe playing environment, identifies conditions that may predispose an athlete to injury or sudden death. The American Medical Association Group on Science and Technology states that every physician is to identify those athletes who have a medical condition and place them at risk and disqualify them from participation or get medical treatment before. Every physician is to not disqualify unless there's a medical reason. Based on research, NATA has developed guidelines regardless of the sport or the athlete's goals, and they also identify conditions that may threaten the health and safety. Your medical and family history. These are your areas of greatest concern. The American Heart Association recommendations for pre-participation cardiovascular screening of competitive athletes. And this is the chart over here on what they recommend. The medical and family history should be reviewed carefully, and both parties questioned and confirmed, so both the student and the parents. Attempt to detect any underlying condition that may predispose to injury, like your musculoskeletal. Your physical examination, you're going to have your vital signs, your height, weight, blood pressure, your visual testing, cardiovascular, neurologic, and general medical, which is your pulmonary, abdominal, genitalia, skin. Your cardiovascular screening, specific questions regarding risk factors of cardiovascular disease. You'll have the oscillation of the heart in both standing and supine positions, and a non-invasive cardiac tested if warranted by findings through your initial history. So an echocardiograph or exercise stress test. Your neurologic screening. If you have a history of concussion, seizure disorder, cervical spine stenosis, or spinal cord injury. A good fact is that there's an estimated 300,000 concussions that occur annually in the United States. And the most common injury in contact or collision sports: football, diving, pole vault, basketball, wrestling. Side note, cervical spine stenosis. It's the narrowing of the spinal canal and or the spinal root passages in the neck. Causes spinal cord and nerves to become compressed and cause pain, numbness, and tingling and weakness in neck, shoulders, and extremities. Orthopedic screening. The musculoskeletal history and examination can be combined if there were no previous injuries reported. More than 90% of injuries can be detected with an accurate history. If any previous injury or other signs and symptoms are detected, you want further site-specific exams. The knee is the most commonly affected, followed by the ankle. Your general medical screening. These are going to be your certain labs: blood count, lipid profile, urinalysis. They're not supported by current studies to have done on everybody, but if you have a history of anemia, then you want a hemoglobin and ferritin tests. Females with abnormal menstrual cycles, you want more lab tests. Diabetes type 1 and 2 should be routinely evaluated for foot conditions, as well as be monitored their glucose levels during activity. Sickle cell athletes should have confirmatory testing and be closely monitored for heat-related illness and dehydration. High cholesterol and those with cardiovascular risks should have a lipid profile. An appropriate management and review of previous labs should be done by the team physician. Medication use. All medications and supplements currently used by the athlete should be reviewed by the examiner of the PPE. Athletes should also be questioned about their use of energy drinks because they can cause symptoms like palpitations and diarrhea. Nutritional assessment. Athletic trainers should be aware of the position statement that shows the prevention, detection, and management of eating disorders in athletes. Heat and hydration related risks. There should be questions related to previous heat related issues. And younger athletes are more prone to these because they don't properly hydrate and drink enough. Mental health. It should be part of your health history. There's questions to determine the mental status of the athlete, and there's a plan for referral and follow-up. Ages 18 through 25 had the highest level of mental illness at 30%. Administration of PPE. Privacy should always be respected, so your HIPAA and your FERPA may be done 4 to 6 weeks before your preseason. You want to complete a new PPE with each level of participation. There's a minimum template for the PPE that was designed by the American Academy of Pediatrics, and that is what you see over here. This is an example of part of that. Both individual and multi-station methods can be used, and a licensed physician is most appropriate to conduct these. Clearance determination. It's based on previous published guidelines and best evidence available. Team physicians and institutions have the legal right to restrict if the decision is individualized, reasonably made, and based on medical evidence. So does the condition pose an unacceptable risk or place the athlete at increased risk for further injury? Can the athlete safely participate with treatment? Can limited participation be allowed while treatment is ongoing? If clearance is denied for a certain activity, can they participate in another? A closer look. It must satisfy 2 major requirements. It must be effective for early detection, and it must be accurate. Abnormal vital signs may withhold clearance until further examination is done. Your head and neck exam. It's going to be inspection of the head, your eyes, the nose, teeth, posterior or pharynx, tonsils, ear canals, tympanic membranes, and palpation of the lymph nodes. A vision screening. You're going to use the Snellen eye chart test, which is the chart here that we've probably all seen many times throughout our lives. Any results with or without correction should be noted. And if there's a significant visual impairment, then you need a complete ocular exam, which is where they dilate your eyes. Pulmonary. Osculation of both anterior and posterior lung fields. Should have symmetric motion of the ribs and diaphragm with palpation. Perform directly on the skin in a quiet environment with slow, deep breaths through an open mouth. Your abdominal. Athlete is laying supine. Osculation for bowel sounds is done first. And you're going to palpate all 4 of the abdominal quadrants, looking for spleen size, liver size, and identifying any masses. Sorry guys, you get the male athlete exam. The contents of the scrotum should be palpated. You should note the presence of 2 descended testicles. Any hernia should be detected, and to do this, the patient is standing, and there's a gloved finger up through the scrotum and into the inguinal canal. Further examinations will be done by the discretion of the physician. Cardiovascular and sudden cardiac death, which we're going to refer to as SCD. This is the most common mortality of U.S. athletes. The most common SCD is hypertrophic cardiomyopathy. The next most common is congenital coronary anomalies. Other conditions may include myocarditis, Marfan syndrome, valvular heart disease, dilated cardiomyopathy, premature coronary heart disease, and myocardial bridge. Here's some statistics. This is based on the chart in our rating, so you can look at that closer. It occurs in about 0.5 per 100,000 high school athletes per year. In only about 25% of those competitive athletes who die suddenly is there an underlying cardiovascular disease detected or suspected before participation. And older athletes, 35 and above, sudden death is usually due to coronary heart artery disease. Compare and contrast. I picked the American Medical Society for Sports Medicine position statement on cardiovascular participation screenings in athletes. There was not a lot to contrast as both documents were very thorough. NATA gives an overall PPE guideline, so they show your abdomen, your lungs, your heart. They go into detail about each. Whereas AMSSM's position statement is only giving guidelines regarding cardiovascular, and it goes into detail about those screenings. The correlation. Both documents state the main goal of the PPE is to evaluate the health of the athlete, to optimize a safe athletic participation, and provide opportunity to assess current and future health risks. Both emphasize the risk factors of SCD. Both present a strong emphasis on getting a family history as well as past medical history. And SCD is the main topic in both documents as it is on the rise. So who's right? I believe they're both right. The AMSSM position statement is a great supplement to the NATA. It provides more detail as far as the cardiovascular. It gives more evidence-based statistics, which can correlate right back to the NATA's position statement. And they are great documents to have to go hand in hand and can combine to make a great source of information. All right, that is it. Thank you. Have a great weekend.